Thank you very much. So as you've heard, I'm an obstetrician gynecologist and I'm a specialist in maternal and fetal medicine. So I'm a clinician, so I look after pregnancy, and in fact on Tuesday night I delivered a baby before I came over to the conference here. I'd like to thank the organisers for the very kind invitation to come. I have been to Lyon before on holidays, but very nice to come here. And it's a real challenge for us as clinicians how to deliver nutritional advice. A lot of healthcare professionals don't feel equipped to do so. We had a lovely visit this morning to Corbus Market, and you can see there was a lot of beautiful fruit and veg. Some of them were very easily identifiable by myself. I guess in Ireland our selection of fruit and veg is not the same as in Europe. But there was one or two I wasn't quite sure of, and I was wondering if you could help me. What about bottom right there? Does anyone know what that one is? Okay, Italian. And bottom left? Man de Buddha. So that was really interesting. I was in Japan in the summer, so I'm trying to marry the pictures of Buddha with the vegetable. So why am I here? We've heard already that Dr. Rita and Dr. Van Can talked about childhood obesity. We can't start early enough. I would put it to you that we should start in pregnancy before birth. Hands up in the audience, those of you who look after pregnant women or are doing research on pregnancy. So there's a couple of people there. So I guess pregnancy is a really important time in a woman's life. It's the only time in the life course where you have two patients in one. So any intervention that you can do to improve the health of the mother will also help improve the health of the baby. Pregnant women, it's thought to be a teachable moment. So we've done behaviour of change assessments in pregnancy, and women are open to change. Unlike most of the population, they're in the contemplative phase. So they're information seeking. They want to do what's best, and they're very motivated by the health of their child. So it's a really good time to introduce lifestyle interventions. It's the only other time in the life course as well where a woman has interaction with healthcare professionals on a monthly basis. So it's a very intensive time, and we can really use this to deliver effective nutritional advice. Of course, the fetus is developing, so it's a very important time to set right metabolic processes that will influence later life health. And we know that nutritional impacts on maternal outcomes. So, for example, nutrition impacts on gestational weight gain, caesarean section, and blood glucose concentrations. So how does this all work? I mean, there's just some science here for those of you that are interested in how pregnancy would impact on fetal well-being. But of course, maternal diet and body composition will influence glucose concentration, energy substrates, metabolic status. These will influence any potential oocyte and embryo responses, resulting in epigenetic modification, metabolic stress. Of course, in pregnancy, depending on the substrate that the fetus is receiving, the baby could be growth restricted or could be exposed to overgrowth. There's a setting of neuroendocrine axis, and then of course the baby at birth then, depending on the environment that the baby has developed in, could be stunted, could be overgrown, and we know that some of you here are members of DOHAD. The fetal origins of adult disease often are set in pregnancy. So we've heard a lot about obesity rates, and this just shows you obesity amongst adults, 2015, our nearest year. And regrettably, Ireland is below the OECD average, and I just put France there, seems to be doing better than many of the other countries, but plenty of room for improvement. So what is causing the obesity rates? Well, the Western diet, rich in carbohydrates, is thought to contribute to obesity. And you're all aware here with your nutrition background that not all carbohydrates are created equal. So low GI carbohydrates deliver glucose over a longer period of time and in more a sustainable way than high GI foods. And this is relevant for pregnancy because in pregnancy, glucose crosses freely into the fetus. There's no barrier. So if the mother has high sugars after eating, that will cross into the fetus and cause relative hyperglycemia. So therefore, a glycemic index may be of particular relevance in pregnancy around fetal growth. So we were interested to explore this, and two of my PhD students, Jenny Walsh and Kieran McGowan, we did this ROLO study. So it was a low glycemic index diet in pregnancy to prevent macrosomia. So we were interested in preventing large for gestational age babies, so babies that we think had received perhaps too much glucose in pregnancy, resulting in overgrowth. So it was a randomised trial of over 750 women. They all had one large baby previously of 4 kilograms. And we were interested to see, could we reduce recurrence of macrosomia or large infant by a low glycemic index diet? So what was the intervention? It was a glycemic index diet, healthy diet in pregnancy. It was eucaloric, so it wasn't weight reducing, and the women were encouraged to exchange high GI carbohydrates for low GI alternatives. So what did we find? We found that the women did adhere to the diet. However, there was no difference in birth weight. So the low GI diet was not effective enough to reduce birth weight. However, there were many maternal benefits: less weight gain for the mother, improved glucose homeostasis, and improved nutrient and food intakes. And I'll show some of you those here. So when you do a randomised trial, of course, when you look at your data before randomisation, you're hoping there are no differences in the two groups. So that's the first line there. In early pregnancy, before the randomisation, there was no difference in glycemic load. But you can see that in second and third trimester, there were differences showing that the women did adhere to low GI diet. What about the rest of the maternal nutritional intake? So the red line there shows you at the time of the intervention between the first trimester and the second trimester, and intervention and control. So you can see that in the intervention group, the number of calories remained quite steady in pregnancy, but in the control group, they increased their calorie intake. In terms of protein, as you know, if you add protein to food, it reduces the GI. So in the intervention group, you can see that protein intakes were higher, slightly higher than in the control groups. And looking at fibre, there were higher rates of fibre intake. We also found significant improvements in fruit and vegetable consumption and oily fish consumption. So this 2-hour group session resulted in very significant improvements in dietary intakes, both macro and micronutrient level. So our conclusion was that a low GI diet had no impact on birth weight, but there were significant maternal benefits. We've had an opportunity to follow this group now from early pregnancy through to 6 months, 2 years, 5 years, and we're now in the process of following mothers and infants 10 years from randomisation. So these infants, we have a lot of information about them. We know what their mothers were eating when they were 3 months fetuses. We have blood samples, and we followed them all the way through. And that's just to show you some of the data that we've collected. So I'm just going to show you some data that we've collected, more on the more recent data. So in terms of pregnancy, and this is Eileen O'Brien, she did her PhD on this, looking at pregnancy as a determinant of future health for the mother. So we know that if a woman gets preeclampsia in pregnancy, she's at higher risk of cardiovascular disease in later life. If she has gestational diabetes, she's at a 50% chance of a type 2 diabetes. So what happens in pregnancy allows us to look into the future, which also means that if we can reduce some of those complications, we may perhaps improve health for the mother lifelong. So we were interested to look at 5 years in the mothers, 5 years after the index pregnancy that I've described to you in the study. We looked at hemoglobin A1C. And we found that if she had more than 3 children, her hemoglobin A1C was slightly higher. If in early pregnancy, 5 years previous, she had slightly high glucose, she was more likely to have a higher hemoglobin A1C. And if she was glucose intolerant at 28 weeks gestation. So showing that glycemia in pregnancy is mirrored in what's happening to the mother 5 years down the road. What about weight gain? So we know, I've shown you the rates of obesity. Interestingly, well-being score change from pregnancy to 5 years was associated with less weight retention. So we heard a little bit yesterday about the interaction of mood and nutrition. Gestational weight gain in pregnancy was associated with increased weight at 5 years postpartum and glycemic load. So again, showing that diet in pregnancy and weight in pregnancy are having influences on the mother 5 years down the road. So in pregnancy, if we want to address adult health, it's an opportunity perhaps to look at weight gain, to look at glycemic control, and really this is evidence that diet in pregnancy and weight in pregnancy are potential targets for later life in health in the mother. What about in the infant? So this is Mary Horn. She did her thesis on the 2-year data. At 2 years and subsequently, we found no differences in body weight in the infants. So this is just pulling out some of the associations. So looking at weight for age at age 2, you can see the correlations there. So you can see that the mother's circumference of her upper arm is associated with 2-year weight for age score. You can see that saturated fat in the diet, and also body mass index of the mother and breastfeeding were also associated with 2-year adiposity. Looking at waist for length ratios, we found again, you can see that the saturated fat is coming up again as associating with 2-year adiposity, and then looking at subscapular and tricep skin folds thickness, you can see glycemic index and saturated fat. So this was evidence for us that it's not just about glycemic index, but also fat intake in pregnancy associating with childhood adiposity 2 years later. So that led on to us looking at fat intake. Of course, we had all this information from pregnancy, and this is Aisling Geraghty. She did her thesis on some of the data I'm going to show you here. So in our population, we found that dietary saturated fat associated with cholesterol levels. So what we all know, that diet is influencing maternal lipids. And then we looked at blood lipids and birth weight, and we found an association. And this graph here just, I suppose, delineates a little bit the relationship. So we're looking at late pregnancy triglyceride correlating with birth weight, but we've divided them out depending on if the mother is normal weight or overweight and obese. And you can see that amongst normal weight women, triglycerides didn't correlate with birth weight, but amongst overweight and obese women, triglycerides did correlate with birth weight. So perhaps a message there that women who are overweight and obese, we need to target maternal fat intake, because it seems to be associated stronger with birth weight. We also looked at dietary protein in pregnancy. So we had 570 Rolo mother and child dyads. We had food diaries in each trimester, and we correlated it with body-child composition. So this is a little bit of a busy slide, but just to, I suppose, this one picture captures the findings. So the scale on the right is looking at the amount of protein. So the lighter the colour, the higher the protein in the mother's diet. And you can see here on the graph, before birth, high protein diet in the mother, and this is in early pregnancy, in the first 3 months of pregnancy, higher diet protein correlated with higher birth weight. But look and see what's happening after birth, up to 5. We're seeing a reverse relationship. We're seeing that the higher protein in early pregnancy, after pregnancy and into childhood, is associated with a relatively slowing of growth. And this has been shown, so it's a little bit counterintuitive that protein seems to be driving fetal growth, but then associated with slower growth in childhood. This has been found in other studies as well. So again, making us think about protein intake in addition to lipids and carbohydrate. So to summarise, in the Rolo kids, we've seen that diet in pregnancy is associated with infant BMI and adiposity. The glycemic index is important, but maybe we also need to look at lipid and protein intake as well. So just to show you one or two meta-analysis, so because we have our birth cohort, we contribute our data into larger groups. This allows for individualised patient data analysis and allows us to interrogate data and find answers in larger groups. So this is 12,000 women from randomised trials and looking at diet and physical activity based interventions. And you can see that the meta-analysis would suggest that all of them reduce gestational weight gain, which is important because that reduces postpartum weight retention and potentially obesity, and also lowering the odds of caesarean section. So I suppose what we're trying to influence here is fetal programming. So you can see that the mother, depending on her metabolic status, depending on her size, her nutritional intake, she may put her child on a trajectory, a higher trajectory, a high-risk trajectory for later life illness. And if the child is at increased risk of obesity and cardiovascular disease, when they themselves come to to have children, then there's a slightly less healthy environment for their fetus. But if we can move the trajectory down to a lower risk trajectory, preconception and in pregnancy result in a healthier infant. And we've heard already that the earlier we start healthy behaviours in life, the better put the child on a lower risk trajectory. So I think we need to look at a life course approach of chronic disease, and I think that's one of the strengths of this conference, that a life course approach is being taken. I'm an executive council member of the International Federation of Gynecology and Obstetrics, and Sian Purander in 2014 set up a maternal nutrition working committee, which is a multidisciplinary group, and we produced some guidelines for adolescent preconception and maternal nutrition. It was quite a challenge because the FIGO has 138 country members, so we had to produce guidelines not only for Western world, which many of us are here today with obesity problems, but also challenges in other parts of the world. And there's some detailed, I would encourage you to have a look at that document if you're involved in delivering advice to pregnant women or before pregnancy, and it goes through what's required for all the stages of pregnancy. And there's also a nice infographic there. And I'd be happy to talk to any of you if you would like to work with FIGO and myself in trying ways to improve healthy advice for pregnant women. So the conclusions and recommendations, and you can see that the WHO, and this was referred to already as well, good maternal nutrition, the best start in life. So maternal nutrition is important, but it requires input from all healthcare professionals. So we do find that the obstetricians say, look, we're too busy to talk about nutrition. That's for the midwives. The midwives say we're too busy talking about normal labour, and that's for the general practitioners. So everyone is pushing it on to everybody else. I think we all need to step up to the plate. Maternal dietary interventions, reduce excessive weight gain, improve glucose homeostasis, and perhaps we need to look not only at glycemia in pregnancy, but fat and protein intake as well. And just thank you to all of the team. Doing randomised trials is a huge amount of work, so just I'd like to thank the team and funders for allowing us to do this work. Thank you.
Thank you for your very nice presentation. We have now time for 1-2 questions concerning this presentation, and we can also have some other questions for all the session, 5-10 minutes at the end. Yes? Up to 20 minutes. Okay.
Thank you very much for this very nice presentation. First question, did you have the opportunity to look at the essential fatty acid consumption by mothers? Since, for instance, arachidonic acid has been said to be a very powerful inducer of adipose tissue development.
Yeah, no, lovely question, but we've had difficulty extracting that data. We have 3-day food diaries 3 times in pregnancy and food frequency questionnaire, but we're having difficulty extracting that particular data from it.
Okay, thanks. And second question, you're on the slides you showed with the evolution of body weight according to protein consumption. Did you have the opportunity to adjust for the child consumption later on in life, or is it a raw data?
No, so it's just correlating the protein intake in pregnancy with the childhood adiposity.
Okay, thanks a lot.
D'autres questions, des commentaires au fond de la salle?
Yes, good morning. Saverio Stranges, Western University, Canada. I have just a general comment question for the speakers on this session around obesity and childhood lifestyle. I was wondering whether I'm a medical doctor, but I think we should rethink about the field of obesity and perhaps push for a paradigm shift, because, for example, I didn't hear about the issue of body weight stigma, and the psychologists will especially in adolescents and young adults, that problem, body weight stigma, may have long-term implications. So I was wondering whether we should really remove our focus on the BMI, which seems to be like the Bible, and perhaps look at different outcomes like increasing healthy diet, also increasing physical activity. So I do believe that it's time for us to as a medical doctor, so say also health professional, to be a little more open-minded around this issue?
Yeah, I might just briefly answer there in terms of pregnancy. So one of our recent studies, we recruited women overweight and obese. But I mean, some of those women with high body mass index were actually quite healthy and fit and were exercising regularly. And so our ability to influence those diets would be reduced. I think BMI is handy because it's a number and it's easy. And we've heard yesterday that GPs have 10 minutes with the patient. So whereas if you want to sit down and talk about their diet, that's going to take longer. So it is helpful, but definitely within BMI you have healthy and unhealthy, and some people with high BMI are just very, very healthy. So it does have its limitations, I agree.